What's up with that? Washington Commanders?
I'll be honest, I would have preferred they lose the line.
All right. Thank you guys for sticking around. We have one breast case to present today. So this is a 40-year-old premenopausal female who presented with a 2-centimeter palpable right-sided breast mass. She, on physical exam, was a D-cup breast size, otherwise normal except for the palpable mass in the upper outer quadrant of the right breast. Imaging was performed, mammogram and ultrasound, which was consistent with the physical exam, showing a hypoechoic 2-centimeter irregular mass. And of note, the patient had a negative axillary ultrasound. She underwent an ultrasound-guided core needle biopsy, which showed invasive ductal carcinoma that was hormone receptor, estrogen receptor, progesterone receptor positive, HER2 negative, grade 2, with a Ki-67 of 40%. She did have an Oncotype DX score sent, which was 22. Genetic testing was performed and was negative, and the patient desired breast-conserving surgery. So she underwent a partial mastectomy with sentinel lymph node biopsy, and the surgical pathology revealed 2.2 centimeters of invasive ductal carcinoma and 2 out of 2 sentinel lymph nodes that were positive. So first questions are, what's the surgical options for this patient? Is she a candidate for oncoplastics? And what would be your axillary management for this patient?
I think you should ask Dr. Gilmore first. Where is his Bengal? Where is his Ravens?
Yeah, sorry, Dr. Cobain. Got a Ravens fan over here.
They're ganging up on you.
Yeah. So surgical options, it looks like she had a partial mastectomy. She would have been a candidate for either a partial mastectomy or a mastectomy technically, but I think she's an excellent candidate for breast conservation. I'm glad you brought up oncoplastics because in this woman with D-cup breasts and a 2-centimeter cancer, I think she's an excellent candidate to undergo oncoplastic surgery, and we're doing a lot more of that these days. You know, as surgeons, we are generally pretty comfortable with level 1 oncoplastics, which is a basic tissue rearrangement. But when you start getting into issues of ratios with larger breasts, larger cancers and smaller breast sizes, we'll often involve our plastic surgery colleagues to help us with level 2 oncoplastics with a mammoplasty or lift on the other side for complete symmetry. And in terms of our axillary management, sentinel lymph node biopsy is appropriate. We know from Z11 that even though she has 2 positive lymph nodes with macrometastatic disease, she does not need further axillary surgery. There's no survival benefit or increased risk of local recurrence.
Sounds great. Does anybody want him to go back and have any more lymph nodes removed?
Hopefully not.
Okay. So then radiation, what are her options?
So she's young, right? She's premenopausal, 40 years old. She's had breast conservation, so she definitely needs whole breast radiation. I think the question here is, do we need to offer her full nodal radiotherapy as well? And she really kind of falls in the middle of 2 different studies kind of looking at an oncotype score, which could help us decide that. These are secondary analyses. Some would argue that they're not necessarily ready for prime time treatment decisions yet, but clinically, I do like to use the oncotype as one of the factors that may lean me in one direction or the other. One of the studies actually looked at an oncotype score of 17 or higher as being increased risk of local regional recurrence. Another study looked at 25 or higher, so she falls kind of right in the middle. But I think with 2 positive nodes out of 2 taken out, young premenopausal and kind of an intermediate oncotype, I probably would recommend kind of full nodal radiotherapy. And what I mean by that is adding a supraclavicular field to treat the supraclavicular areas and not just level 1 or 2 of the axilla as well.
With only 2 nodes?
With 2 out of 2 nodes and an oncotype of 22
So
and a premenopausal patient, yeah.
So the oncotype is what's driving that?
Well, I think not just the oncotype, but some of the other kind of high-risk features, the fact that she's young, premenopausal, yeah.
What about the whole breast accelerated radiation? Can you talk about that a little bit? She may not be a candidate, but...
Right, so You mean if I was just doing whole breast radiotherapy, would I do something more ultra hypofractionated? Is that the question? So there are new kind of whole breast regimens, newer, I should say. They've been around for probably about 5 years, a little bit longer than that. Looking at, instead of giving, let's say, 15 to 20 fractions or 3 to 4 weeks of radiotherapy, giving just a 1-week course of radiotherapy. I think that is a potential option for a lot of patients. One of my concerns with that study is that we don't have cosmetic outcomes out past 5 years. And so for some patients, they don't care as much about the cosmetic outcome of the radiotherapy, and I think that, therefore, for those patients, that is a very good option. But there are a lot of patients, after talking about aquaplastics and the type of surgery that is done as well, I think cosmetic options, cosmetic factors are important to them, and I try to lean them away from the ultra hypofractionated until at least we have the data on the 10-year cosmetic outcomes. And there is some concern from other studies that do have 10-year outcomes that cosmetic outcomes might be worse with ultra hypofractionated. So I think we're probably about another 3 years away from getting that data.
So much of our discussion today will be about what her adjuvant treatment options are. I just put a case recap here. So premenopausal, oncotype of 22, ER/PR positive, HER2 negative with 2 of 2 lymph nodes. What would you guys recommend for her adjuvant treatment?
So I guess I'll go first. So, I mean, she's young, and so when we look at these patients that are premenopausal with several lymph nodes positive, I mean, she has about a 20 to 25% risk of having a recurrence. And so we want to be able to prevent that. And one of the things that we now know is that when patients are premenopausal, looking at that RX Ponder data, which was a small portion of premenopausal women with this similar circumstance, we know that still adjuvant chemotherapy, adjuvant IV chemotherapy is still going to be the mainstay for her. There's always this discussion of, TC versus, ACT. I think certainly TC could be an appropriate option for her in this case. There's also been, discussion on adjuvant CDK4/6 inhibitors that we now have approved from Monarchy with the abemaciclib, as well as the Natalie study with ribociclib. And we saw the data from ESMO that in a Natalie study, these young premenopausal women that received adjuvant ribociclib for 3 years had improved outcomes and decreased their risk of relapse. So certainly, all of those modalities will be discussed with patient. And while she was receiving her adjuvant endocrine backbone with the CDK4/6 inhibitor, we would recommend ovarian suppression.
So, Erin, would you do anything different? And how do you make a decision about CDK4/6 inhibitors?
Yeah. So I agree with everything that has been said. I think the only thing that's worth really mentioning in addition is the fact that we have we have an ongoing clinical trial really that is relevant in this setting. So the Offset clinical trial is a study that is really looking at patients who are premenopausal with either node-negative disease that have a high oncotype or node-positive breast cancer, and seeing whether or not we may be able to safely eliminate chemotherapy for some of these premenopausal patients, and whether or not ovarian suppression plus endocrine therapy really achieves adequate outcomes. One of the reasons that this is an incredibly important study is because the Responder clinical trial, which was just mentioned, the vast majority of those patients actually received adjuvant tamoxifen as their endocrine therapy. They did not receive ovarian function suppression. And so when we saw this really difference between postmenopausal patients and premenopausal patients, I think an outstanding question is it really that the tumor is biologically different in a premenopausal woman and they do benefit from chemotherapy? Or is it possible that all the chemotherapy is doing is actually leading to the suppression of the ovaries? And if every patient in that trial had ovarian function suppression, would the outcomes have been equivalent? So the Offset trial is actually trying to answer that question, and patients are randomized between chemotherapy followed by endocrine therapy with ovarian suppression versus no chemotherapy and endocrine therapy with ovarian function suppression. I also want to highlight one other thing before we talk about the CDK4/6 inhibitors, which was just, it was mentioned, TC chemotherapy could be considered, and I think that's very appropriate as well. And I just want to highlight the data that was just presented at the San Antonio Breast Cancer Symposium, looking at the potential benefit of anthracycline therapy on the basis of oncotype score. I think that data was compelling, and there's also been similar data presented looking at patients who have had mammoprint testing, suggesting that the patients with higher scores tend to benefit more from anthracyclines, whereas patients with lower scores perhaps don't have as significant a benefit from anthracycline therapy. So that's other data to kind of take into consideration. And then with regards to deciding between a CDK4/6 inhibitor, we've obviously not had a head-to-head comparison of ribociclib and abemaciclib. I think that oftentimes this discussion is motivated by toxicities that are anticipated with these therapies, as well as duration of therapy. Abemaciclib is a 2-year duration. Ribociclib is a 3-year duration. In general, I think obviously ribociclib much more likely to cause cytopenias, some nausea as side effect, whereas with abemaciclib, diarrhea is the most predominant side effect. So I don't think there's a right or a wrong answer. I think you have to kind of talk about all of the options and see how patients would prefer. Although I guess one quick point would be for this patient, I'm not sure she's actually abemaciclib eligible. I don't remember what the grade of the tumor was.
She's grade 2.
Grade 2, okay, so actually ribociclib, was there a key 67? Oh, got
Yeah,
it. Okay, so then would be eligible for both. Yes, would be eligible for both.
So 2 comments here. One is the offset trial, BR009. We have that at West, and if you have patients who meet criteria, please feel free to refer. And the second option, second comment here is one of the things that we don't talk about a lot, but I bring it up whenever I get the opportunity, is the drug-drug interactions with ribo, especially in the community setting. There's a lot of drug-drug interactions that we need to pay attention to that can prolong your QTc, especially when your patients are going to physicians who are outside of your system and they're starting different drugs. So you have to let your patients know that if your physicians are starting new drugs, they either need to do the interactions and make sure there are no interactions, and or let you know of what is happening.
And so the last thing that we just wanted to talk about was, does genetics matter in this patient? If she came back and had a BRCA mutation before the surgery, would you recommend something different?
Yes, I think that if she had a BRCA mutation, we would certainly discuss, her lifetime risk of a second breast cancer and prophylactic surgery on the contralateral side as well. And I think that applies for the BRCA mutations, PALB2, various other mutations as well.
What about from a systemic perspective?
Yeah, we certainly could consider adjuvant PARP inhibitor as well. And sometimes we're faced with this dilemma for patients that have ER-positive, HER2-negative breast cancer that qualify for both an adjuvant CDK4/6 inhibitor and adjuvant PARP inhibitor, and what do you do? I think that many of us are leaning toward the PARP inhibitor as sort of our initial adjuvant systemic therapy concurrent with adjuvant endocrine therapy in patients that have a BRCA1 or 2 mutation, largely just because I think the data from the Olympia trial is quite compelling, and obviously that's a targeted therapy for that population. It's not as non-specific as the CDK4/6 inhibitors. One of the other questions that's been raised, which I don't think any of us really have a good answer to, is whether or not you actually could sequence PARP inhibitor and CDK4/6 inhibitor. So for example, could you give the PARP inhibitor for the year and then do 2 to 3 years of CDK4/6 inhibitor therapy? I'm curious what Erica's thoughts are.
I think,
And also comment on whether you'd ever think of combining all 3.
what now?
Combining them.
Would you ever combine all 3?
So no, for the combination. A lot of interactions, a lot of side effects. But I think, in this particular patient, when you look at the Olympia study for the triple negative, there wasn't a lymph node criteria. But specifically in the hormone receptor positive patients, they had to have, I think, 4 or 5 lymph
They
nodes.
had to have 4.
Yeah, 4 lymph nodes or more. So she's, at that point where she has 2, but if you look at the FDA indication, it leaves that open. To discretion. And I certainly think that PARP inhibitors are very, one of those medications that are very tolerable for patients.
Yeah, so I would definitely agree with that. I think the study was designed to be positive, to have its best chance of positivity. So we select a really high-risk population. It doesn't mean that the intermediate risk didn't benefit. And if you have a patient for whom you think may benefit from olaparib in the adjuvant setting, based on your just clinical gestalt, I think try to get it for them.
Looks like we have a question.
In the community with a lot of clinical study, how do you, with the adjuvant CK4/6, how do you select a patient for hormone suppression? So is the question, how do you select which CDK4/6, or how do you select?
Ovarian
Or the
suppression.
ovarian suppression.
Versus chemo.
Yeah, so it's always, you guys want to take it. The question is, do you do it with tamoxifen, do you do ovarian suppression, and how do you make a decision?
I mean, generally, in all patients that are high enough risk to merit chemotherapy, I am recommending ovarian function suppression as a component of their adjuvant endocrine therapy.
Yeah, same here. And I think what is really exciting is getting that information from the offset study, because this particular patient, maybe chemotherapy is really not going to be as beneficial as we think, and that the bulk of the relapse-free survival is going to be on ovarian suppression.
So the other thing I would add to that is there is an approval with tamoxifen with abemaciclib, so that's an option. However, you have to think about an increased risk of having thrombosis. So you should follow those patients closely. But you could do that with abema. You should not do that with ribo because of increased arrhythmias.
Yes.
This lady, how you presented this case, a premenopausal lady. First, she got oncotype DX on her biopsy. And then, on surgery, she has 2 positive lymph nodes with extracapsular spread. So do you really think you will base your treatment decision based on oncotype on this lady?
So in this setting, for the systemic therapy, no, particularly not. And, even now, the makers of Oncotype, right, are very selective in not allowing, biopsy tissues to be taken get an Oncotype on the biopsy tissues, because that we know that, about anywhere from 12 to 15% of patients, even though the ultrasound's negative, physical exam is negative in the axilla, will have a positive lymph node, and that may change the trajectory of the systemic therapy.
And I'll make a couple comments on that. Number one is Oncotype in the neoadjuvant setting. I believe there's been, maybe some of the medical oncologists can comment on this, but there's been quite good agreement between the biopsy Oncotype and the surgical specimen. And so there are a lot of women that we can actually apply neoadjuvant therapy on these women when we get that Oncotype before surgery and get some good prognostic information. The second comment I'll make is with the extracapsular extension that you mentioned. So we have to be very careful to distinguish gross extracapsular extension from microscopic extracapsular extension. The Z11 trial only excluded patients with gross extracapsular extension, and we don't see that very often. That's like in the operating room, you find that the lymph nodes are obviously, enlarged and firm. Whereas, even if this pathology report would have said positive microscopic extracapsular extension, she would still qualify for Z11 criteria.
And I'll just add a few more comments. I think the root of your question is about whether or not we should be making decisions on the basis of anatomic risk versus genomic risk in a premenopausal patient. Right, and I think the answer to that question, at least in standard therapy, is that as of right now, if they are node positive, they merit chemotherapy. That's the standard of care. The only context in which I would consider utilizing the oncotype score to defer chemotherapy would be in the context of a clinical trial, such as the offset clinical trial. And then I'll just echo what was said about using gene expression profiling assays, largely really to help us understand who we may be able to treat with neoadjuvant systemic therapy, because as was mentioned, it does look like there is high concordance between gene expression profiling score on a core biopsy versus on a surgical specimen. But I always am honest with my patients that have, gene expression profiling on a core biopsy. If it comes back in the lower end of risk, that doesn't mean you won't need chemotherapy. And I think that that's a very important thing to sort of make sure patients are fully aware of before they go to surgery, because if, for instance, we sort of at surgery have this surprise that they have multiple lymph nodes involved, that data is going to, at least in a premenopausal patient for sure, take precedence, and standard would be to give chemo.
And just from a radiation perspective, just really quickly, I know we're out of time. But sure. What I was suggesting before is that in this situation, I'm actually not using the oncotype to help me decrease treatment. Although there is data to potentially support that in this patient, I am more worried about kind of the overall picture of what she's showing us. As a young premenopausal patient with 2 out of 2 nodes, even though, yes, not gross extracapsular extension, but microscopic extracapsular extension, grade 2, higher Ki-67, I am a little bit more worried about this patient than I would be a typical patient who went on Z11. And so, yes, that's why I'm recommending kind of more aggressive therapy than I would have, even though there is some data suggesting that maybe in somebody who has a lower risk oncotype may not need full nodal radiotherapy.
But biology does matter.
Absolutely.
And that's what genomics is looking at. Thank
All
you
right,
very
thank
much.
you guys.